I thank the organizers of the NBSTRN Summit for inviting me to share share my experiences with SMA newborn screening implementation in Wisconsin. I'm our site's principal investigator for AVEXA's clinical trials, for which my institution has received research funding. I'm also the site principal investigator for the Risdiplam Expanded Access Program, which is a compassionate use program that's sponsored by Genentech Roche. While my patients have benefited from early access, my institution does not receive any funding from Genentech Roche. So during this talk, I'd like to speak, before talking about the implementation of SMA newborn screening in Wisconsin, I'd like to provide a brief overview of spinal muscular atrophy, which is an important inherited cause of pediatric death and disability. I'd like to talk about SMA disease pathogenesis and its unique genetics. I'll then cover the new treatments for SMA, which were part of the rationale for newborn screening for spinal muscular atrophy. The new treatments include Nusinersen or Spinraza and gene transfer therapy or Zolgensma. Both are highly effective, especially if given early in the course of disease. We'll then talk about SMA newborn screening and how in Wisconsin we're trying to ensure that treatment can be started when it is most likely to be effective. So spinal muscular atrophy, it's severe weakness due to lower motor neuron dysfunction and death. This lower motor neuron impairment is due to deficiency of spinal SMN protein, also known as survival motor neuron protein. And this is required for lower motor neuron growth and development. Patients with SMA have normal brain development and function and normal cognitive development. The incidence is about 1 in 10,000, and SMA occurs in all populations. This is a diagram of the upper motor neuron that goes from the brain to the spinal cord, which is intact in infants, in children with SMA. So they are cognitively normal, and many are considered to be quite bright. The lower motor neuron, however, from the spinal cord to the muscle, degenerates and dies, leading to severe muscle atrophy. So the spinal muscular atrophy is, as I said, due to deficiency of SMN protein, and that's due to the loss of both copies of the SMN1 gene. And the loss of SMN1 gene is almost always due to deletions of the gene. Complete lack of SMN protein is incompatible with life. So children with SMA do have some SMN protein production, and that's because of a nearby but flawed and nearly identical gene called SMN2. SMN2 generally produces a mostly non-functional close copy of SMN protein, but occasionally it can be mistranscribed to produce normal protein. People with SMA, therefore, are missing their SMN1, and then SMN2 produces a small amount of non-functional SMN protein. So the more copies of SMN2 you have, the greater amount of SMN protein you have. And people can have varying copies of SMN2, 1, 2, 3, or more. So this slide shows the different types of SMA. There's a range of phenotypes associated with SMA. You can have children who present very early in infancy. They're said to have type 1 disease. They are never able to sit. So this infant will always be unable to raise his arms or legs, and generally will grow and develop primarily lying on his back. Without medical intervention and support, children with SMA type 1 will die by around 2 years of age. And those children generally have 2 or 3 copies of SMN2. Type 2 disease are children who are a bit stronger. They are able to sit, but they often lose that ability to sit unsupported. They're never able to stand. And they often, with support, durable medical equipment support, and other ventilatory support, usually at night, they often live very long and productive lives. So they can certainly live into adulthood. Many of them go on to college and professional school afterwards. Interestingly, they often have 3 copies of SMN2, but some may have fewer or more. Type 3 SMA are children who have they're able to stand, but again, they often lose that ability as they grow older and bigger. Their age of onset is they're usually diagnosed in the toddler years because of some unusual feature about the way they walk, and they tend to have more copies of SMN2. What's interesting about SMN2 is that the number of copies you have does not strictly correlate with how weak you're going to be. So we have patients with type 1 SMA who have 2 copies. We have patients who have 3 copies. So the copy number doesn't precisely give you the phenotype. But it's clear that SMN2, the more copies of SMN2 you have, it can be somewhat protective. And so the obvious question is there a way that you can make SMN2 produce more SMN protein? And scientists have developed a way to target splicing signals on the mRNA using antisense oligonucleotides. And those antisense oligonucleotides really convert the SMN2 mRNA to looking like the SMN1 mRNA, and therefore making more abundant functional SMN protein. So the name of the antisense oligonucleotide that was studied and then FDA approved is Nusinersen. And it was shown to improve motor outcomes in children with type 1 SMA who had, children were enrolled who had 2 copies of SMN2. And really what this is just one figure from the paper from Finkel et al. In New England Journal of Medicine, which described the results of dosing children with Nusinersen. The red line depicts the natural history of spinal muscular atrophy type 1 in infancy, which is that these children lose the ability to breathe on their own. So the red line is a survival curve of the onset of requiring permanent ventilation, which is defined as tracheostomy or needing significant ventilatory support for greater than 16 hours for a day for 21 continuous days. Whereas the group that received Nusinersen was able to largely avoid ventilatory dependence. Now, it should be said that this study was in symptomatic children with SMA type 1, so they were already weak. And as weak children grow, they do have a harder time managing their breathing and movements. The other feature of SMA type 1 is that there is no motor development, essentially. So these children start out weak and floppy, and they never are able to gain head control or any motor milestones. And so again, the red group, there is no bar for the percentage achieving head control, sitting, or standing. Whereas in the blue group who received Nusinersen, even though they were symptomatic, a certain percentage was able to achieve head control, sitting, and standing. So this was a very exciting result. And this is a picture again of a boy with SMA type 1 showing the how these children progress if they're given medical interventions to help them survive. Matteo spends much of his time on his back, and his breathing and his feeding are supported. His brother, Javi, who's being held by his parents, received Nusinersen in another trial. So I presented data from the NDER trial, which was in symptomatic SMA type 1 patients. Javi was treated pre-symptomatically at less than 2 weeks of age, and he was started on Nusinersen at that time. So in this photograph, he's about a year of age, and he has head control and was able to sit, though he was a little bit delayed in achieving some motor milestones. The protocol that he was in really showed that Nusinersen, or this antisense oligonucleotide, would achieve even better outcomes if given early. So these infants in the Nurture trial were all treated at less than 6 weeks of age. And so the Nurture trial is still ongoing, and they just announced their results from about 4.5 years of after the study started. And so this is for pre-symptomatic SMA patients who have 2 or 3 copies of SMN type 2 and were treated before 6 weeks of life. And Now, after the study has been going on for about 4.5 years, 100% of the 25 children are still alive. None have needed permanent ventilation, and nearly all are able to walk without assistance. So, just a little bit about Nusinersen or Spinraza. It was FDA approved in December of 2016 for all types of SMA and all ages, though they're basing the recommendation on studies that showed efficacy best in SMA type 1, especially when given before 6 weeks of age. Nusinersen is a drug that needs to be given intrathecally, and it needs to be redosed regularly. The cost of the drug is high. It's $125,000 per dose. And in the first year, 6 doses are required due to the need for having 4 loading doses in order to get a therapeutic level, in the spinal fluid. After that, it's a dose every 4 months, so 3 doses a year thereafter. As I said, it's intrathecal delivery, so there are additional procedure costs for the lumbar punctures, and oftentimes these children require sedation. It was disruptive and revolutionary to think that SMA type 1 patients could be treated, and in fact could be treated, and if treated early, could have such a remarkable improvement in their outcome, surviving and gaining motor skills. And really, it was the commercial availability of Nusinersen that led to the approval of SMA newborn screening in 2018. Also, at that time, we were aware that another drug was being tested, and this was gene transfer therapy of SMN1. So we've been talking about ways of improving on the existing SMN2 copies that children with SMA have, and sort of hijacking their mRNA in order to produce more SMN protein. But another logical way of addressing the disease is to simply introduce the SMN1 gene that is missing in these children. The drug that was developed provides the SMN1 transgene to the nucleus via an AAV9 capsid. The transgene is modified in such a way so that there is no delay in initiating transcription once it's in the nucleus, and it is always set to transcribe. Safety studies of this gene transfer technology were extremely exciting. So these were children who were all symptomatic with SMA type 1, and it was really a study meant to look at appropriate dosing. All of the children who were enrolled in this phase 1 trial exhibited exhibited the ability to gain motor milestones. So there was no control group, but the red line shows a historical control of, again, what happens to children with SMA when they are untreated, what the natural history, as it were, of SMA type 1. So this shows the likelihood of requiring long-term ventilation or permanent ventilation. In the group that was in the phase 1 group, none of the 15 children enrolled required ventilatory assistance. And likewise, if you look at the ability to gain milestones, again, the natural history of SMA is that there are no milestones that these infants can gain. They don't gain head control sitting or standing. Whereas in the group that was treated with gene therapy, they were able to make motor gains. So the FDA recently approved gene transfer therapy called Zolgensma in May of 2019. And this is for children with spinal muscular atrophy who are under 2 years of age. They also have to be, they also have to show that they've not been exposed to AAV9. So having AAV9, existing AAV9 titers is a contraindication to receiving Zolgensma. It has some serious adverse effects soon after administration. So there's a black box warning about liver toxicity. Children often develop transient thrombocytopenia and elevations in troponin as well. While troponin is commonly seen as a cardiac marker, it does not seem to be associated with significant cardiac dysfunction in children with SMA type 1. Still, because of these adverse effects, which are thought to be largely related to immune response, Steroids are started the day prior to dosing with Zolgensma and then continued at least for a month. Close laboratory monitoring is also recommended. So there are 8 scheduled lab draws that are recommended over the subsequent 12 weeks after infusion. And as you are aware, the cost of this drug is also quite high. It costs $2.1 million, and that's for the drug alone. It doesn't include the doctor's visits and the lab draws. So to this point, we have talked about SMA, which is a severe progressive disorder of weakness due to degeneration of lower motor neurons occurring in approximately 1 in 10,000 births. The loss of lower motor neurons is due to a deficiency of the critical protein, SMN protein, which is primarily made by the SMN1 gene. That gene is missing in children with SMA, or a functional copy of the gene is missing. Still, SMN protein is produced at low levels by SMN2 genes, and there can be multiple copies of these genes in children with SMA. New drugs that target SMN1 and SMN2 have been shown to prevent disease progression and maintain the viability of lower motor neurons. So if these drugs are given before lower motor neuron degeneration, that is, before any signs of clinical weakness, then motor development in these children may be normal. In type 1 SMA, weakness is usually seen by 4 to 6 weeks of age. Therefore, newborn screening for SMA can make very early diagnosis possible, hopefully before the loss of a significant number of lower motor neurons. Of the 2 treatments available, Nusinersen has fewer systemic side effects as a drug than gene therapy does. Still, Spinraza must be given every 4 months by lumbar puncture, and that's after the initial loading period. Gene therapy is a one-time dose, and both are very expensive. But as you can imagine, from a family perspective, faced with a newborn with spinal muscular atrophy, there are many advantages to Zolgensma or gene therapy, which is why it tends to be the drug of choice following newborn screening. So now I'm going to switch gears and talk a little bit about Wisconsin's SMA newborn screening program. I've highlighted Madison and Milwaukee. The children's hospitals in these 2 cities are the centers for referral when the newborn screening lab identifies an infant with spinal muscular atrophy. Wisconsin began screening in October of 2019. The annual birth rate in Wisconsin is approximately 65,000 births. So far, we've identified 5 infants with SMA, including one that we just identified last week. So that's 5 infants in approximately 10 months of the newborn screening program. And so I would say that overall, we're sort of on track for having an incidence of approximately 1 in 10,000 in Wisconsin. So the clinical management after screening is outlined by this flow diagram. So first we'll have a positive newborn screen, and then the newborn screening lab communicates this result to the PCP, and then the PCP, with the help of the newborn screening lab, decides on which center, Milwaukee or Madison, they'd like to refer the infant to. Then the newborn screening lab makes the neurologist at that center aware, and the neurologist is also made aware at that time of the SMN2 copy numbers, which our newborn screening lab also determines. The neurologist contacts the primary care provider to provide advice about the need for urgent follow-up. And typically at Madison, at least, I encourage the PCP, unless they have a longstanding relationship with the family, to let me call the family and sort of put the clinical follow-up, the clinical short-term follow-up in motion. What I do want to know from the PCP is if they've seen the infant and if the infant appears clinically well. All of the patients who've been born in Wisconsin have been clinically well. And so what happens then is we encourage an urgent clinic visit for confirmatory testing and pre-treatment testing, with the focus being on treatment with Zolgensma or gene transfer therapy. So our confirmatory testing consists of SMN1/2 confirmation, as well as AAV9 titers, and then the liver function testing, troponin, CBC, and PT are all meant to screen for liver, platelet, and cardiac issues prior to dosing. We then start the prior authorization process with the baby's insurer in order to get authorization for treatment with Zolgensma. And the goal is to treat with Zolgensma, preferably before the third week of life. If the infant is not clinically well, if they appear to be symptomatic, if they look like they may have a very severe form of spinal muscular atrophy, which we term SMA type 0, which is usually associated with one copy of SMN2, we would consider transfer into the inpatient setting for further evaluation. At the first visit, we discuss so if the child is well and they come in for an urgent outpatient visit, we discuss the natural history of SMA and treatment. There, I have a PowerPoint presentation, not too different from this one, in which I sort of give families background, and then we have a number of information sheets and packets to give them as well. But even before that visit, we determine the insurance information and we pre-notify the prior authorization team. Then blood is drawn, as I said, for SMN1 and SMN2 copy numbers. And in our state, Zolgensma has been given to those with 2, 3, and 4 SMN2 copies. We draw AAV9 antibody titers and what we call pre-Zolgensma labs, but these labs are also drawn after Zolgensma is dosed over the subsequent 12 weeks after dosing. The treatment phase occurs after we receive prior authorization to be allowed to treat with Zolgensma. We did a lot of pre-work as the newborn screening program was getting set up to talk with the major third-party payers that work with our institution about the need for urgent prior authorization in the setting of newborn screening. And most of our big payers have agreed to provide urgent prior authorizations after newborn screening. So then how do we ensure that the infusion itself is safe? This is a $2.1 million drug being given by intravenous infusion over an hour. There's a lot of stress associated with that. And so, again, we engaged in meetings with our infusion center and pharmacy to ensure a very smooth workflow. Prior to the day of infusion, we start steroids, and this continues for a month. And then we also put a schedule in place for all of the post-infusion lab draws and visits. And so the question that we think about, but we have fortunately not had to address yet, is what to do if we have an infant who clearly seems symptomatic. It's not just that they have a little bit of difficulty with head control, they are needing more urgent respiratory support and feeding support. A symptomatic infant with SMA is likely to need, as I said, support for breathing and eating, and we may need to be discussing artificial feeding and immediate respiratory intervention. The baby will likely have to come in an inpatient setting, and these interventions are likely to delay treatment. As you can imagine, insurers are not as certain that these medications will be beneficial to an infant who is already severely impaired from their SMA. In addition, Zolgensma and Spinraza are generally not given to inpatients. Because of the high cost of these drugs, hospitals are particularly reluctant to give them in an inpatient setting. They prefer to give them in an outpatient setting. So these are the things that we've been thinking about, but like I said, we've not really faced this situation yet. So in summary, to me, the goal of SMA newborn screening is to ensure that children are treated promptly before their lower motor neurons have a chance to degenerate. So the protocols we have in place are meant to ensure that an infant with who is destined to have type 1 SMA will be able to start treatment before 3 weeks of life. And at UW, I do focus on initiating treatment with Zolgensma rather than trying to sort of look at the options between Zolgensma and Spinraza. I've certainly not had a family who has told me that they would prefer that their child be dosed with Spinraza, for example. Cure SMA recently updated their newborn screening recommendations, advising that infants with SMA who have 4 copies of SMN2 should be treated early, just like those with 2 and 3 copies of SMN2. And that partly that has to do with the fact that there is a reported case of a child with SMA type 1 who has 4 copies of SMN2. Another issue to be aware of is that sometimes AAV9 titers are positive in an infant. We think that's possibly due to maternal transfer, and that these antibodies will come down when rechecked. We generally recommend rechecking in 2 weeks, but that opens up an uncomfortable situation in which we may want to start treating before we wait to retest antibody titers. And that would be a situation for considering Spinraza or Nusinersen. I would say that despite the black box warnings, infants in the first month of life seem to tolerate Zolgensma fairly well. Thank you so much for your time.